I'm really pleased to be here today, and it's great to see such a large number of people here who want to climb the hill with us. And remember, when you've climbed the hill, there's always a really good view from the top, so keep going. So I'm currently doing two jobs, like lots of people in the room, I suspect, in the NHS. I'm the Medical Director for Clinical Effectiveness at NHS England, and I'm the Interim National Director of Patient Safety. And so that's given me a really great opportunity to actually join up some of the work that I've been involved in NHS England and some of the work that's going on in NHS Improvement to improve the quality, safety and effectiveness of patient care. And one of the things that I'm part of, and I'm very, very pleased to be part of, is the Infection Prevention and Control Steering Group. So we bring together people from the diagnostic side, people who are working on the gram-negative bloodstream infections, people who are working on sepsis, people who are working on antimicrobial resistance. And we try to ensure that we have an allied approach, and you'll be really pleased to hear that we're trying very hard at the centre to take a joined-up approach to healthcare improvement in the same way as we're exhorting you to do in your localities between community services, acute trust, mental health trusts and primary care. And what I've been asked to talk to you about today is just a very small part of the work that I'm involved in, and that's the sepsis CQUIN. I started professionally as a general and colorectal surgeon and practiced for 10 years as a consultant, so I saw a great deal of sepsis, and I certainly caused my fair share of it as well. But I'm aware of its impact on patients and their families and on carers, because people who've had major abdominal surgery unfortunately often spend a long time in hospital if they get serious infection as a consequence of their condition or their treatment. And one builds a relationship between the carers, the patient and their families, and some of these people are on wards or on ITU for 6 to 8 weeks with terrible abdominal wounds and then may not survive after that. So it's a huge impact on individuals, but of course it's also a huge impact on the costs to the health service. So I'm absolutely passionate on doing everything that we can to reduce the risk of serious infection and sepsis, both for patients and for those of us who work in the NHS and for the taxpayer. So when I started working at a national level, my first role was as the National Director for Reducing Premature Mortality. And the programs at that stage were largely around cancer and cardiovascular disease. And I said, but hang on, at the sharp end, we see an awful lot of serious infections and sepsis in hospitals, and I think it's important that we do a program of work on those as well. And at that stage, I didn't know what the levers were. And I said, well, can we get something into the standard contract? And I was told, no, there's no point in trying to get something into the standard contract if it's not being addressed well in a lot of places already. The thing you need to go for is a CQUIN. And so I went for a CQUIN. And I got together a group of people who felt equally strongly about sepsis, and we tried to work out what would be most effective as a CQUIN in order to take this work forward. So we wanted to have a sepsis CQUIN that would be of value and usable in the real world. And we were all very keen on the Sepsis 6, but the combination of 6 different things was too complex to use as a CQUIN, and that's why we focused on using assessing people for sepsis if they're acutely unwell, and prompt treatment with antibiotics as 2 key parts of the Sepsis 6 that we felt would be measurable. And when we started the CQUIN in 2015, we started it in emergency departments, and then we rolled it out to inpatients thereafter. I'm really pleased to be able to say that the Sepsis CQUIN has actually done pretty well. And over time, prompt assessment for sepsis in the emergency department had gone up from 52% to 89%, and the inpatient assessment had gone up from 62% to 75%. And then prompt antibiotics within an hour of recognising sepsis had gone up from 49% to 70% in ED and 60% to 80% in inpatients. And that includes the switch across to not just starting the antibiotics promptly, but also ensuring that there was a 3-day review. And if you look at that from the graph point of view, you can see we've got a way to go yet, but we have had a steady improvement so far. The blue line is emergency patients and the red line is inpatients over time. And then in terms of treatment, getting the IV antibiotics in, went up and continues to rise. But again, we're reaching a point where I don't know whether we're going to make more improvement or not. Now, of course, this is national data, and it's an average. And what it hides is the fact that there are some trusts with actually very high rates of prompt identification and treatment, and other trusts with very low rates. And so you need to look at your own data against these averages to see where you stand. And I wanted to see what we could do to help incentivize people to improve. And one of the things that we've recently done, and I hope some of the recipients are in the audience, we sent letters to the 20 trusts that had most improved their performance on the sepsis CQUIN. Not the best, but the ones who were most improved. And I have to say, from the feedback that I'd had from the chief executives that I wrote to, I got a huge amount of thanks, and they were really pleased to be able to pass the messages on to their staff. So if you're sitting in the audience and you're from one of the trusts that got that message, well done. I'm really, really proud of you. Now, I went and talked to the Secretary of State about having done that, and he's very keen that he can write to trusts about good news as well. And so what he's asked me to do going forward is every quarter, when the sepsis CQUIN data is updated, to let him know who are the best trusts and who are the most improved trusts. And it's quite possible that he may then write to your chief executive, if you're one of those, to say well done too. So that's something to think about when you're trying to improve your sepsis work. There is something also about the fact that not all trusts are actually submitting CQUIN data. I was quite surprised to see how few it is. So less than half of all trusts are actually submitting sepsis CQUIN data. So if you're in the audience and you're in a trust that's not submitting the data, I'd be really interested if you could get in touch with me and let me know what the barrier is that's stopping that happening in your trust. Because for an average large trust, the money that's available if you perform well on the CQUIN is over £500,000 a year. So what's not to go for? And there are trusts that have been effectively using their CQUIN data to fund their sepsis nurse and other parts of the sepsis program. So I would strongly encourage you, if you're in a trust that's not submitting the data, to do so. And if you don't think you can, get in touch with us and we'll see what we can do to help you. I've been asked to include a slide on changes in how to upload the sepsis CQUIN data. Can I quickly say I am not the expert on this, and I won't be able to ask any questions beyond what's on the slide. You'll need to contact Helen Wilkinson in the team about it. But Unify is no longer the way that the CQUIN data is uploaded. It's now through NHS Digital. It's just come into effect. And the Part 2C, which is the 3-day review, and the consumption of antibiotics continue to be collected by PHE, but the sepsis end of it is moved from Unify 2 to NHS Digital. And so if you need advice from that, as I say, I'm not the expert. What are our ongoing challenges? Well, first of all, is recognising that although sepsis is really important, it's not the only cause of acute deterioration. Trusts are using early warning scores and increasingly commonly the National Early Warning Score to recognise acute deterioration, and I'll say a little bit more about that going forward. But a high news score by itself does not equal sepsis. It equals a person who's sick, who needs senior clinical assessment and a judgment as to whether or not the cause is sepsis, and taking it on from there. But not all organisations or individuals have recognised that there is that second step. There's also the challenge for people in trusts trying to find a random sample of inpatients that's, well, truly random is difficult, isn't it? And trying to find enough people who've actually got a raised early warning score to then make the assessment when you're doing the audit to find data to submit for the CQUIN. And if you look at the number of patients that were sampled and submitted on the CQUIN data, 107 trusts that submitted data, between them submitted 27,000 patients. And the 2 trusts that are using an electronic patient record to submit their CQUIN data submitted 590,000 patients over the same period. So those 2 trusts are actually assessing every single patient who comes into their major emergency department and every single inpatient, every single time they have their observations taken. Those are automatically being assessed to see if there's a high early warning score, and if there's a high early warning score, then they know that those are the patients to assess for sepsis. And so there is something very, very different in the ability of different trusts to be able to do this. And if you have an opportunity to encourage your trusts to talk to the ones that are already doing this and to find ways to move towards an electronic platform, it could remove an awful lot of the bureaucracy that relatively junior staff are spending a lot of time doing, and sometimes relatively senior staff such as sepsis nurses and infection control consultants. So we're aware that there's a problem with the time taken to collect the data, and the sorts of solution that we're encouraging are those which use an electronic record, an electronic platform to record the vital signs, to calculate the early warning score, and then to make an alert where appropriate. I think when we first talked about the CQUINs a couple of years ago, there was a tension between the sepsis and the AMR CQUINs, but we were able to discuss that and to come to an agreement that actually it's two sides of the same coin. It's really important that we consider sepsis and AMR together. Many of you will be aware that in this year's sepsis CQUIN guidance, we are suggesting that the sepsis team and the AMR team should be the same team in a hospital so that you're working towards the same end, which is the right treatment for the right patient at the right time and not treating people who don't need it. How have we done in terms of outcomes on the sepsis CQUIN? Well, bearing in mind that we've only asked trusts to upload small samples of the patients who might have sepsis, the modelling that we've done suggests that the number of lives saved just through the introduction of the sepsis CQUIN in those trusts is more than 1,600 lives over the last 3 years. So between you and your colleagues out there have saved over 1,600 people from dying from sepsis through your work. So again, thank you for doing it. It's a really good piece of work, and there's still more that can be done. Bear in mind, this doesn't really get us into the trusts that are not submitting any CQUIN data at all. What are we doing for the future? Well, first thing I need to notify you of is that we are really keen to support News 2, the new version of News launched by the Royal College of Physicians in December. It's supported by the National Quality Board, it's supported by NHS England, it's supported by NHS Improvement. We're supporting it by asking people who are submitting sepsis CQUIN data to ensure that their trust is using News 2 by the end of 1819. So you've got about a year to get this sorted. And we're going to offer ways to help people to do that, and you're going to hear a little bit more about it later on from Matt Kim. The reason we want to move to a single early warning score system is that we will reduce the difficulties in communicating between different parts of the healthcare system. We know that there's one city in Britain where the two different major trusts use different early warning scores, and in one of them a high score means the patient's sick and in the other a low score means the patient's sick. That cannot be a safe system. All the ambulance trusts are going to move to News 2, and 75% of acute trusts are already using it, so we want you all to get there, and you'll get a bit more detail about that later on. We also know that we need to keep working together between the sepsis and the AMR teams, and I've told you that how we're intending to do that. We also need more work done to actually identify who really needs immediate antibiotics and in whom it would be safe to wait for a few hours to get some characterization of what infection they've got in order to target the antibiotics better. And I'm really pleased to be able to say that we've got some work that is underway, some of it through NHS Improvement and some of it through Public Health England, to start to take this forward. And in parallel, the UK Sepsis Trust is doing some work with the trust in the southwest of England and a couple of others to try to identify this as well. If you've got work going on in this space, we're really keen to hear about it so that collectively we can start to identify who really needs those antibiotics and the other treatment quickly and who we can wait. And then I think the last point is to reiterate that message about electronic recording of vital signs, automatic calculation of the National Early Warning Score, and automatic alerts to somebody who's senior enough to deal with that acute deterioration so that we can find sepsis and treat it in all the people who are getting it.